Welcome to the Menopause Hour, your go-to source for empowering answers to your burning menopause questions, the ones you won't get from your OBGYN. Brought to you by Winona, menopause care made easy, and hosted by our experts, CMO Dr. Michael Green and Medical Director Dr. Kat Brown.
Hi, everyone, and welcome to a Winona Live Q&A with our Winona doctors. We're so glad that you're here tonight and really glad that you took the time to be with us. And we know that we're starting a little bit late tonight, so we're also so grateful that you took the time to wait and take the time out of your schedule to be here. We know that it really is a lot. Kind of when you just lean into, taking charge of what your medical journey looks like, and kind of everything that goes into that. So we just want to say a really big thank you as well to you being here and taking the time. I just also want to remind you, if you have never been to a Winona Q&A, we are so excited that you are here. These are a really special time that we get to spend with everyone and kind of get to connect everyone and hear your questions, get your questions answered. It's a really special time. So you can go ahead and start putting your questions in the chat. Make sure it's toggled for everyone. Usually this gets a little bit crazy up in the chat, so go ahead and start putting your questions in there now, and we will get to those as soon as possible. But if you've been to a Winona Q&A before, you know that we love to give a chance to our wonderful doctor who is here with us today, Dr. Green, a chance to kind of introduce himself. So I will give him a chance to do that, and then we will jump into your questions. We'll talk all things Winona, and we'll get into it. So Dr. Green, thank you so much for being here, and I will pass it off to you.
So hi, I'm Dr. Mike Green. I'm the Chief Medical Officer of Winona. I want to apologize. All of a sudden, 2 nights ago, we were filming content in Texas. My knee just went out. And so I was at the doctor's office. It looks like I have a torn meniscus, but you know how doctors are. I went to the doctor's office, took forever. So, but it was really important for me to make this appointment. So I apologize for being late. That's what's going on. So if I'm a little rough and ruffled, so to speak, that's what's going on. But we're here to answer your questions. I am a board certified OBGYN. I actually did a family practice residency first, so I do both. And it's a joy to be able to provide healthcare, particularly healthcare that people can't get from their regular doctor in many circumstances, in a very convenient way online to y'all. And I know for some people, they go to their doctor, they have all these symptoms, and their doctor poo-poos them or ignores them, or I don't feel comfortable with that. And they have no way to get medicines that they truly need. And so that's what we're here for. If your doctor is comfortable with HRT and they know what to do and they're happy to do it, that's fantastic. That's great. And if not, we're here to fill that gap and make sure that people have access to the care they need, because unfortunately, there's just so much misinformation about HRT, even among doctors in the medical community. And, people are just afraid of it when they shouldn't be, and it's just a big access problem. So anyway, we're excited to be here for you. It goes best if you ask questions, because I'm going to run out of things to say. I could tell you about my trip to Austin and Houston. I'd like you to hear about it. So please put some questions in, and let's talk all things Winona and HRT and menopause and anything else you want to ask me.
Absolutely. Well, Dr. Green, I was going to say also, I think on behalf of everyone who's here, but also I love coming to these, and I think that it's just so great to see. I know that you have such a busy schedule too, and just getting to see you taking the time out of your schedule, and like you were saying, kind of out of your own doctor's appointments, and kind of what that looks like in your life as well, to give some of your time to be here and answer the questions. I think really means so much to people, and I think that is just I think really just such a real marker for what Winona stands for as well. It's kind of just helping people get access to doctors, and kind of what that looks like to get really holistic, like medical care and like what that looks like in menopause. So I think that we're all really, really glad and so excited that you're here. And I know you're kind of maybe a fan favorite is a good way to put it among kind of the Winona community. So we love having you on these webinars for sure. But I will say the starting late has not necessarily stopped the questions. I still see a number of questions coming through. So that's always great to see. Let's see. So I think the first one we have tonight is coming from Melissa. And Melissa says, I had a complete hysterectomy at 25. And she says, I'm now 53. She says, would this work for me, do you think, Dr. Green?
So it depends on what she means by complete hysterectomy. So unfortunately, there's a disconnect between the language that doctors use when they talk about hysterectomies and the way that patients use. So to me, a hysterectomy is removal of the cervix and usually the removal of the uterus and usually the cervix. And so to complete or total hysterectomy medically means uterus and cervix. But a lot of times when people say that, they mean uterus, cervix, and ovaries. And it makes a huge difference because it's the ovaries that make the hormones. So if all you had out was your uterus and your ovary, at least one ovary was left, then this may be a reasonable thing for you depending on your symptoms. If they took everything out, your uterus and your ovaries, and you've never been on HRT, it's really kind of too far post having your ovaries out to think about it. It's kind of, the opportunity is gone. So really, you need to get on HRT within 10 years of going through menopause, or in this case, if it was a surgical menopause, within 10 years of going through surgical menopause. So if it was just your uterus, then you may be a great candidate for these medications. But if both your ovaries are removed, almost 20 years ago, then the door's kind of closed on that, unfortunately.
Thank you so much for that answer, Dr. Green. And it looks like our next question is from Alicia. And she is wondering, is it safe to take progesterone without the estrogen if you still have a uterus?
So it is safe to take progesterone without the estrogen. The question is, why would you want to do that? It's the estrogen that really gives all the benefit. We use progesterone as sort of a necessary evil because estrogen is what gives almost all the benefit. The problem with estrogen is that it can overstimulate the lining of the uterus. So if you still have a uterus, you need to use progesterone because it keeps the uterus nice and thin. Hey, Kat.
Hi, I had to get my laptop out because I couldn't get the sound to work on my big desktop.
Oh no! Hi, Dr. Pat. We're so glad you're here.
So I was telling you don't know, I was telling about my meniscal tear that happened when I was in Houston filming all that kind of stuff. Anyway, so now I lost my train. What was the question again? I'm sorry.
Sorry, I distracted you.
No. We're so glad you're here. It's always fun
too.
like the whole gang together. It's always a good time. We had a question from Alicia who was just wondering, is it safe to take progesterone?
Oh, that's right. Yeah, the progesterone.
Right.
Okay, yeah. So progesterone needs to be added to the estrogen so that you don't overstimulate the uterus and it balances out and it keeps everything safe. And it's really important. However, it's really estrogen where almost all the benefits coming from. And in fact, if you don't have a uterus, we prefer to give you just estrogen and not progesterone because there's some risks and side effects to progesterone that are better to avoid. So like the biggest one is that, for the most part, HRT does not raise breast cancer risk to any great extent. But for women that are on estrogen and progesterone both, there's a small increased risk. For women that have had a hysterectomy and are only on estrogen, there isn't an increased risk because it's not estrogen that causes that. It seems to be the progesterone. Progesterone sometimes can stimulate appetite and cause a little weight gain, usually not in the doses we use, but there are some other issues with progesterone. So in general, in my opinion, there's very few times when you would want to use progesterone without estrogen. Honestly, it's kind of backwards. You're taking the risk without getting the benefits. Like, well, that's kind of the wrong way of doing it. So, the answer is yes, it's safe to take progesterone without estrogen, but why would you? So that's kind of the bigger answer.
Absolutely. And it looks like our next question comes from Mary. And Mary is wondering, she says, can high testosterone cause early morning anxiety and panic the second I barely open my eyes? She says this has looked like heart pounding and adrenaline rushing for no apparent reason.
I don't know if it's testosterone alone that's doing that. I mean, there are so many other neurotransmitters in our brain that are biologically active that could be the source of that. But if this is happening when you're first waking up, my big concern would be, what is the quality of your sleep? So definitely something to start tracking and trying to work on sleep hygiene, trying to make sure you get a good night's rest. That might be the big thing to look at first. Sorry, I'm going to have a little visitor hiding behind me here.
Oh, I like it. Hey, a couple more of these, she'll be answering the questions.
Right?
Exactly.
The only caveat I would say is that if you've got a testosterone pellet, that can be a side effect of the testosterone pellets. But if you're just, no supplements, no testosterone externally that you're taking, this is almost certainly not a testosterone issue.
Absolutely. And we have a question next that's coming from Elena. And Elena says, hi. She says, thank you so much for this Q&A. She says, I'm new and was wondering about bleeding and spotting after starting HRT. She says, I saw some comments on Facebook, and she says, I just want to be prepared in case it happens to me. She also says, I have not had my period since almost a year. What can I kind of expect with this?
Well, if you've gone almost a year, but not a full year, you might not actually be done. I've had patients go 11 months and they start the countdown and then another period comes coming back. So, we can't say that you've completed the transition into menopause until you've actually gone a full 12 months without a cycle. And for most women, that happens like around age 52. But it can be common for some women to experience spotting or bleeding when they first start HRT because the uterus is responding to the hormones somewhat. It doesn't mean every woman's going to experience it, but it's something that we definitely want you to communicate with us about if you're starting treatment. We want to know, but it's not uncommon. Some women do experience that. So just because you see other women posting about it on Facebook doesn't mean it's going to happen to you. So don't worry about that. And just with anything on social media, regardless of where you're looking, you're going to see a lot of people be very happy with treatment or be very upset. You don't see a lot of the middle of the road. And the bulk of the patients that don't experience a side effect. So just keep that in mind and take it with a grain of salt too.
Absolutely.
Yeah, you're much more likely to make a post when something unbelievably outstanding is happening or something really terrible is happening. When life is okay, it's there, everything's just chugging along. You don't really talk about, who makes a post? Yeah, life's good.
Absolutely. And then I rarely get to add anything onto this conversation because we have two amazing doctors here. But I just wanted to add as well. Also, we're so glad if you are in our Winona Women's group on Facebook. That is a great community to be a part of and to find support and other women who are going through the same thing. But just want to urge you as well that if you're kind of seeing comments like that, a great place to reach out to is your doctor. Those kind of medical discussions really, you want to make sure you're having those with a doctor as well. Those are really important to have there as well, or on live Q&As like this, which are super exciting. But just also want to bring that back to the forefront as well. But thank you so much, Elena, for your question. And it looks like our next question is coming from Melissa. She says, can not having the appropriate hormones cause hair loss? And then she kind of adds on, she says, and I might need your all's help a little bit on the pronunciation here. I love these parts as well. But she says, everything is gone. She says, oh, I'm going to pronounce this wrong. The oophorectomy as well. Am I saying that right?
Pretty good, Maddie. You did it.
There we go. Perfect. Next up, I'm going to be the next one taking these questions. So sounds good.
Yeah. So, I think that's hair loss is one of the most common complaints we get from patients, just in perimenopause and menopause itself. There's so many hormonal fluctuations that can affect the hair follicles and their life cycle that it's a very common symptom that many patients discuss when they're going through this time period in their lives. So, not having the right hormones can be part of it, just the fluctuations of hormones. Not only that, but our hair also responds to stress. illness, all kinds of things. So, it can be multifactorial. Typically for most patients that are starting HRT though, once the estrogen kind of gets established in their body, usually that hair loss starts to slow down a little bit. And overall, you tend to have better quality of the hair follicle, skin gets better, and the hair is a part of the skin organ. So it's definitely something that improves. So long-term, women notice benefits to the strength and the quality of their hair, the thickness of their hair, the longer they're on HRT.
That's a great answer. And it looks like our next question is coming from Mary. And Mary says, what is the best dosage of estrogen to help with symptoms, but more importantly, prevention and protection?
Well, there's not a one size fits all for every patient. And so that's something that, I don't know, we wouldn't want to say like the best dose is this and then have all patients run out requesting that dose. It's really individualized. And I think that that's an important thing to take into account. But for the most part, we tend to err on the side of starting low and titrating as we need to until we get your symptoms under adequate control. That's much better and much safer for you as a patient than going high and then having to adjust backwards as you experience side effects or things like that. So there's not a one size fits all. So that's my answer.
I would say all of our doses that we use should give you the long-term estrogen benefits. We start with that. It's like, we've got to give you enough to give you the cardio, the cardiovascular protection, enough to keep, the osteoporosis risk down and all that stuff. And then the next step is, now how much do we need to add to get your symptoms under control? So any dose that you're going to get from us is going to give you the long-term health benefits. Now it's a question of what does it take to get your symptoms under control? And yeah, our philosophy is we'd rather have to add, we'd rather have someone come back and say, gee, it's helping some, but it hasn't got all my symptoms under control, then, oh my gosh, it's making me miserable, right? Mm-hmm. So rather give a little bit extra and get the symptoms even better than have to dial back because, we've caused you problems. We don't want to cause you problems.
And it looks like our next question is coming from Heidi. And Heidi is wondering, she says, what are the recommendations for HRT now for women classified as high risk for developing breast cancer?
Well, so I guess that we would have to further clarify what you mean by high risk for breast cancer. So, specifically, there are some women who can carry a genetic predisposition for breast cancer. And so in those situations, if a patient chooses to go on HRT but is BRCA positive, it's something that you really would need to be closely monitored and followed because you have a much higher risk of developing breast or ovarian cancer than the average woman in the population. However, if you have a family history and you think you're like very high risk because, an aunt had breast cancer or a grandmother had breast cancer, even your mother, doesn't mean that you're going to get it too. And so that's something that you're still a candidate for HRT. And I just want to throw it in there too, that so many of us grow up as women being afraid of breast cancer. And I think that that's one of the universal fears that a lot of women have when it comes to thinking about hormone therapy. But you are much more likely to die of a heart attack than you are to die of breast cancer. That's the leading cause of death in women. So I think that's an important caveat to take into account when we're having the discussion about breast cancer, because I think that, there's a lot of fear mongering. You see a lot in the news about breast cancer, and we all have this fear of it. But it's generally pretty rare for you to get breast cancer and die from it compared to like heart disease. But yeah.
There are these online tools that ask all these questions and they come up with this, you have this risk of breast cancer. And I don't know how well those things have been vetted. And so I think it's a lot of fear mongering. And I think they're pretty much pulling the number out of a hat, quite honestly. And that's a totally different thing than, like Dr. Kat was saying, I've got BRCA or I've got Lynch syndrome or one of these, well-known syndromes or genetic markers that can seriously cause issues. But these online tools that people use, and then it gives them some number, I don't know if those have really been vetted.
And it looks like our next question is coming from Lyridra. And she says, hi, I have almost all symptoms of perimenopause symptoms, and my quality of life has been negatively impacted. She says, my OBGYN told me I can't use bioidentical hormones because in the past I've experienced migraines with aura because of the risk of complications. She says, I urgently need to do something with my hormones, but I also need to understand the real risks. Can you please clarify a little bit more about this?
Sure. And I wonder if her name is pronounced Loreda. I don't know. I'm not sure. I was just looking at the name, and my daughter's like getting really close because she's reading the questions too. But in this situation, what we know about migraines with aura, the real risk applies to synthetic birth control hormones, which are generally much higher dose than hormone therapy. So what we know, and the research has shown, that with birth control hormones, if you have a history of migraine with aura and you take those medications, you could be at higher risk for having a stroke. That risk does not apply the same as hormone therapy. So generally, a lot of women get migraines with hormonal fluctuations. They can be triggered by menses. They can be triggered by hormone changes in perimenopause. For me personally, I actually started getting migraines as a perimenopause symptom, and mine resolved with starting hormone therapy, which is the case for a lot of patients. I've seen a lot of my patients have a similar experience. So just because you've had that counseling from your physician, that really applies to birth control. And this medication, using hormone therapy, especially bioidentical hormone therapy, is much different. The risks are much lower. And so it's not an absolute contraindication. And I have plenty of patients who have had migraine with aura that I safely prescribe, and they do very well. So I think that's an important thing to consider.
My absolute favorite patient, which is my wife, has migraines with aura, and she's on Winona bioidentical HRT. And I love my wife, married 37 years. Believe me, I don't want her to have a problem. So if I didn't think it was good, I absolutely would not have my wife using it. So I can't think of a better, put your money where your mouth is, right?
Right.
That's how strongly I feel that it's safe. And I think your OBGYN may be a little misinformed about this.
Mm-hmm.
Absolutely. And our next question is coming from Kelly. And Kelly says, hello, I'll be 60 in January. When do I stop HRT?
Well, it's really a personal decision when you decide you want to stop. So, and the important thing is that if you're turning 60 and you haven't yet started, that's a whole different conversation. But if you've been on hormone therapy and you're doing well with it and you feel like a better version of yourself on the medication, it's really up to you when you want to think about stopping. It's a personal decision. Years ago, we used to recommend that women take it for the shortest duration they needed to, just to kind of get over the hump. But now, so many of us are seeing such health benefits and the preventive benefits it has for our cardiovascular fitness and our bone health, and also, our cognition and our brain health. So for me personally, you're going to have to pry it out of my hands. You're not going to take it away when I turn 60. And I think a lot of patients feel that way now too. But ultimately, it's a decision you make with your doctor. And as you age and as your medical history may change, if you get new diagnoses or new problems, you might have to reevaluate your medications. So it's just, individualized again. So each patient might have a different timeline.
Yeah, that age 60 is a magic number for starting for the first time. And that's why people get confused. But, if you've been on it, it's just another number. And it doesn't really mean anything risk-wise.
Absolutely. And our next question tonight comes from Stacy. And Stacy is wondering, are these hormones safe for someone who's had a medical history of blood clots?
Well, in this situation, if you have had a personal history of a deep venous thrombosis or a pulmonary embolism, which is a DVT is when you have a blood clot in the leg, or a PE is when that blood clot then goes to the lungs. So if you've had one of these and you had a risk where they put you on blood thinners, or they treated you with that, or you still need blood thinners, you're at much higher risk than the average population. So you need to be careful with any medication that could increase the clotability of your blood. So it doesn't mean you're not a candidate, but you're really not a candidate for a low risk service like ours, which is telemedicine, where we can't physically examine you and do like in-person testing and examinations. We can't look in your medical records to follow you more closely. So not a candidate on our site, but that doesn't mean you can't see somebody in person and have the conversation.
And we have our next question is from Emily. And Emily is wondering, can you talk a little bit about checking serum hormone values prior to HRT? She says, I've had some issues with the doctor not answering this question.
Yeah, so we always wait to find out how deep into the webinar we're going to get this question, because we answer it every single time.
So yeah, so who had 15 minutes?
But yeah, so the big answer to this is that hormone testing is not necessary to start HRT. It's really not helpful for us at all. So if someone is requiring you or requesting that you get hormone level testing, then they really are not comfortable with managing menopause hormone therapy, because we don't really find any benefit to doing it. It doesn't give us any added information. Your hormone levels can vary so much from day to day, during, from the time of day, how you're feeling one day versus the next. And the problem is you can have a whole constellation of symptoms, but then you go to get your hormones tested and they're normal. So it gives us absolutely zero information. So this is a medical condition that, unlike other blood tests where you check a blood test, give a supplement or give a medication, this is better treated based on a symptom log. So I'd much rather have a patient get a symptom tracker or start to mark down on a calendar, like how often are they having hot flashes? What other symptoms are they having? That's much more, useful information for me as a menopause specialist than getting hormone levels.
Yeah, it's one of the more misunderstood things with HRT, which is why we get this question every time, and we both jump on it. But, and I think most of the people most of the providers, the doctors, or practitioners, or what have you, that ask for hormone levels, they think they're doing the right thing, and they just aren't well versed in HRT. They see the Quest lab sheet. Oh, there's an estradiol there. Okay, I can get that. And they don't really understand all the ramifications and how, the sort of subtleties of why it's not helpful. Unfortunately, there's also a small subset where it's just a big moneymaker.
Yes.
There are, unfortunately, less scrupulous clinics and, platforms and what have you that, we can make a lot of money doing labs, but that's not what we're here for. We're here to take care of people and do healthcare in the best possible way. And labs just aren't helpful.
Yeah. And I'll just throw it in there. This is not an opinion unique to Winona. This also, the Menopause Society, which is a national society of menopause practitioners, does not recommend labs getting drawn. Also, ACOG, which is our College of OBGYN in America, also does not recommend getting labs prior to starting hormone therapy. So it's not just Dr. Green and I that are saying this. This is a universal recommendation from all those that are comfortable in treating menopause patients. So.
And our next question tonight comes from Maritza. And she's wondering, she says, what is the process once you join Winona? And she says, once you join Winona, do you see a doctor and then they decide what you need according to the symptoms? Or what is that process like? She says, my symptoms happen to be lack of continued sleep and hot flashes and mood swings.
Yeah, the process is pretty easy. You just go to our website. First, you'll select your state where you live to make sure that we have services available in your state. And if we do, it'll say, yes, you're eligible. We're in your state. You'll get an online adaptive questionnaire that'll ask you the pertinent medical history that we need to know to make sure that this is a safe treatment option for you. And then it'll ask you about symptoms. So there's an area where you'll mark what symptoms you're suffering from. And then it'll give you options and show you some of the general different forms of medication that we have available and ask you if you have a preference. And if you really don't, you can not select something. And what happens is your chart then comes to one of our Winona doctors for review. We review your medical history. If we have questions, we might message you to try to clarify something. Or if you hadn't chosen a preferred treatment method, then we might give you some options and talk to you about different options. And then we come up with a treatment plan together. But the other important thing is that you don't need to schedule a live video visit. You don't need to schedule a Zoom call or anything like that. This is asynchronous telemedicine, which for some women, I think it's something they don't expect, because if you've had other telemedicine experiences, you've had to schedule an appointment and wait for it, just like an in-person visit. But the nice thing about asynchronous is that you can message us anytime, and it's real time. And so your doctor will get back to you when they're back on the portal. Our general standard is that we want our doctors to get back to you within 24 hours. Sometimes it's a lot sooner. Sometimes we might be online and we see your message pop up and we write back right away. And that's kind of neat when that happens, when we're both online at the same time, because then you can actually have a real dynamic conversation and go back and forth if you need to. But yeah, that's the process. And then if and when we decide to prescribe, the medications are ordered, they're sent to our pharmacy, and they're mailed directly to you. So there is no having to take your prescription to the pharmacy, wait in line, wait for the pharmacy to fill it, pick it up. All those time wasters are gone, which is actually kind of nice. And the medication comes right to your mailbox.
Yeah, when I designed the onboarding process, I hate when I go to the doctors and they give me this giant book that I've got to fill out in the waiting room, right? Of a million things that make, I'm there because I have a bad knee and that I have my tonsils out. What does that have to do with my knee? So, you filled those out before, right? And so it's like, I don't want to do that to people. I want safety. What information do I need to do this safely? That's number one. What information do I need to do it correctly? That's number two. And then don't ask anything else. Like, why ask all this superfluous stuff? So we try to make it as streamlined as possible to get all the information we need and none that we don't. And some people are surprised because, and sometimes they're upset, you didn't even ask me anything. It's like, well, I asked you everything. I just didn't ask you all this stuff other people ask you that have nothing to do with anything, right? So sometimes that's a surprise how simple the process is. And for some people, they feel like, well, how could this be done safely? You didn't ask me anything. It's like, well, we did actually. You just didn't realize how much we actually asked you in a packed little thing and got all the information we needed. Mm-hmm. And I would say, depending on the doctor and their comfort level, somewhere between 70 to 85% of the patients, we get all the information they need. They've gotten all the information they need, and we just send them the prescription, and easy peasy for everybody. And I think it's a great way to do it. But on the other hand, if patients have questions, we're very happy to answer them. If we have questions, we'll ask you. But most of the time, we have the information we need to do it safely and correctly. So that's the two big things.
And our next question comes from Yvette, and she is wondering, she says, I'm 52 and I had my uterus removed in 2011. She says, is it too late for me to use HRT? And then she says, I hope not, because I ordered it from Winona and can't wait to get it. So we'll see what your answer says.
So if only your uterus was removed and you still retained your ovaries, that means you didn't go through menopause at the time of your surgery in 2011. So that means it's perfectly safe for you to start treatment now. So generally what happens is the uterus removal, you stop having periods, right? Because the bleeding organ's gone, the offending organ has been taken out, but your ovaries will still keep doing their thing. They don't realize that their friend, the uterus, has been gone. So they will still keep functioning, providing hormones, trying to ovulate, even though there's nothing to receive it. And so, that means you still are going through a natural menopause when your ovaries are aging like everyone else who didn't have surgery. So it's perfectly safe in that situation.
Yeah, and I would say that based on what you told us, because I know that we asked you if your ovaries came out as a separate question, and the doctor prescribed you, so you must still have your ovaries, because it would have happened otherwise. So again, there's the information we've gathered, and I feel very confident that the doctors did the right thing.
And our next question tonight is from Mary, and Mary is wondering, can testosterone cream cause anxiety?
Well, we talked about this a little earlier with that patient that talked about waking up and feeling extreme anxiety. Just testosterone treatment alone may or may not, but, Dr. Green mentioned if you have a pellet, because that's a much larger dose or depot of, testosterone that's placed in pellet form, it's possible. I personally don't prescribe testosterone cream, so I can't speak to experience level to see if that's something I've had patients complain about. But anxiety can be from a variety of reasons.
Testosterone can do that, and if it started right after you started testosterone cream, it's possibly related. So it is one of the potential side effects of testosterone therapy. however it's given, although much more common in pellets because it's such a much higher dose. But the cream, different people have different sensitivities to medication.
Absolutely. And our next question is, I have used progesterone creams in the past, but my appetite increases a lot. And then she says, another question with this is, can hormonal imbalance cause dry eye issues? And why are my body aches suddenly, or why do body aches suddenly appear during perimenopause? And she also says, I'm 52 at this time.
Mm-hmm. I have had a lot of patients in the perimenopause transition talk about dry eye. It also can be a function of aging itself too. But the joint pains are kind of ubiquitous, and a lot of patients experience joint pain, especially during this midlife transition too. And my answer to that is that estrogen is beneficial in so many tissues in the body, and I don't think we realize how much it has a role in our joint spaces too, like with the lubrication in the joints, the cartilage of the joints, and the function of those. It makes a huge difference, to put estrogen back in the circulation. All the tissues in our body, really function optimally when they have estrogen available for women. Same thing with testosterone for men. It's one of those things that these are our powerhouse hormones as a woman, our estrogen. And so we really just function our best, and our body works its best with estrogen around.
Let me touch on the progesterone part of that question.
Mm-hmm.
So progesterone in high doses certainly can stimulate appetite. We see it there's a birth control method called Depo-Provera, which most of us hate because it causes so many side effects, and weight gain is a big one. So we'll give somebody a Depo shot, they come back in for the next shot 12 weeks later, and we weigh them. It's like, oh gosh, they're 50 pounds up because it can really stimulate appetite. It happens. It's a lot less common with HRT for two reasons. Number one, depending on what progesterone, but for the progesterone we use, the micronized progesterone, bioidentical progesterone, it's much less likely to cause that than the synthetic progestins. In fact, Megace they use for people that are anorexic to help them gain weight. So it depends on what you've used in the past, and it depends on the dose. So it's possible that someone gave you too high of a dose of progesterone cream, and that's why it caused weight gain. And it may be that imbalanced in a smaller dose that's still adequate for protection of the uterine lining. You may not have that side effect, especially balanced with estrogen.
And it looks like our next question is from Melissa. And Melissa says, I'm 56 and looking to start BHRT. She says, my mother-in-law used regular HRT years ago and had a stroke due to them. So she is worried about me starting. She says, how does the risk differ from HRT versus bioidentical HRT?
So, I think the main issue and the main difference is the type of medications. And if it was a long time ago that someone started hormone therapy, some of the earliest medications we had in this space were, conjugated estrogens, which was basically Premarin, which is the oldest known HRT, which stands for pregnant mare's urine. It was derived initially from the urine of pregnant horses. And so there was a lot of extra horse estrogens that aren't even biologically active, that were in those medications. And what happens is if you're given a synthetic form of a hormone, your body doesn't incorporate it as well. Whereas bioidentical, basically that just means that these hormones are identical structurally to the hormones that your body's creating on its own. So we're able to use lower doses to achieve the results we need because the body recognizes these hormones easier than a synthetic version. Also, hormone therapy has evolved so much over the years too. So years ago, there really weren't any options for transdermal methods like creams and patches and gels. So almost every woman was taking things orally. And in order to have enough hormone, to circulate, the doses were much higher, I think, back in the day than they are now. So that could also be part of it too. So.
Yeah, we've come a long way. The other thing is that, like we've talked about the age of 60 of starting hormones. I can tell you when I first started my career, that's a long time ago, the standard of care at that time was like everybody should be on hormones. We started 80-year-olds on hormones, which now is like ridiculous. Like, I can't believe I did that. But at the time, we thought it was the right thing. So that's, excuse me, that's another change So, we don't know the care she got, but it was a long time ago. It was good care at the time, but we've learned so much more that we can do it so much better and so much safer.
Mm-hmm.
And our next question is coming from Heidi tonight. And Heidi says, can you please talk about the benefits of HRT for low libido, brain fog, insomnia, etc.? She says, we hear so much benefit of HRT for vasomotor symptoms, but I'm having none of those, fortunately. But she would love to hear about some of those other ones.
And some women don't get those vasomotor symptoms until later in their transition. So I think the insomnia and the brain fog are probably two of the earlier symptoms that a lot of women experience. And basically, by adding in estrogen into your circulation, it really improves the function of our neurotransmitters. It really helps with cognition, and that's what really treats that brain fog. So when we lose estrogen from the brain cannot optimally process thoughts, memories, remembering people's names, remembering what you went into another room for. So commonly, it's just hard, where you may have been someone who could multitask and really stay on top of everything. And then suddenly in perimenopause or menopause, you struggle with that. And that's so very common. And that's really improves with the addition of estrogen in your system. With the insomnia too, I think that's another thing that also, really greatly improves. Generally, a lot of times when you're awakening in the middle of the night, it's like your normal rhythm of staying asleep is gone. Sometimes you could be having night sweats without really knowing it too. So sometimes you might wake up and you might have trouble getting back to sleep. Unless you actually woke up in a sweat, it's hard to know that you actually had a night sweat that kind of awakened you from sleep. But generally, when we add in HRT, sleep is more sound. Women tend to, have an easier time falling asleep and staying asleep with less nighttime awakenings too. And then when it comes to libido, ultimately, giving you hormone therapy helps overall by improving the quality of the tissues in and around your genital area, your reproductive tract. Our DHEA supplement really helps significantly with libido, though, because what it does is when you metabolize that, it gets broken down into estrogen and testosterone. And I don't think a lot of women realize that the testosterone basically, really is a big force in your libido and your sex drive. But the other aspect of this too is that when you're suffering from so many vague and weird symptoms and you're just not feeling comfortable in your own body, how many of you feel sexy if you're feeling that way? So if we treat these other symptoms and make you feel more like yourself, and then you get your confidence back and your body feels better, you're sleeping better, you're going to be much more likely to be interested in intimacy. And so that overall can help libido too, indirectly.
And I had to say one more thing, is that you're the kind of patient that Winona was built for, because you're very likely to be, ignored or at least put off by your regular doctor, because they may not recognize these subtle signs of menopause transition. Oh, you're not having hot flashes? Oh, this isn't that. This must be something else. And you get misdiagnosed. You get other they get put on other medications that can have other side effects and don't really help. And so here, you have doctors that are expert. This is what we do, and we understand these subtle signs so that they don't get ignored or misdiagnosed, and they get treated. So you're the kind of patient I love, because the other ones are easy, anyone can do it, but these ones are, they're a little more challenging. You really need expert care, and that's what we're here to provide.
And our next question tonight comes from Kelly. And Kelly says, could you please explain why it's not a good idea to start HRT after the age of 60?
Yeah, so this has to do with the length of time it has been since you've completed menopause, but also as we age as women, if you have not been on hormone therapy and your body has had the lack of estrogen from those tissues, basically the risk is increased for cardiovascular events that are adverse. So as we age, the arteries around our heart can get hardened and get calcifications. The muscle of our heart starts to age. And so basically, if we add in hormone therapy after that, irreversible aging process has already occurred, there can be a slight increase in adverse events as far as heart attack, stroke, blood clot. But generally, it's one of those things that if you're on it for a longer period of time, like if you were on HRT and you hit age 60, that risk is not the same because you've been getting the benefit of keeping those tissues healthier over that time. So it's really the first starts after 60 that we worry about that have that increased risk. And it's a temporary risk, but it's within the first 3 years, Dr. Green?
2 years.
Yeah.
2 years is where the lines cross. So what happens, there's actually a slight increased risk in the first 2 years of HRT. If your baseline risk is really small, that increased risk is basically insignificant. But if your baseline risk is higher, it becomes significant. And so over 60, the number for the first 2 years is 7 events per 10,000 women. So it's not a huge number, but it's not zero either. Once you get through those first 2 years, the lines cross now, and you've had that 2 years of benefit of estrogen, and so that risk goes back down. It's kind of an interesting thing. So someone much smarter than me, did the statistics on this, and 60 was sort of the magic number where those lines crossed, and the risk became, big enough that it, at least it causes a pause and a conversation, and really think about, gee, is it worth taking this extra risk now that didn't exist before then? So, and let's be honest, if you're, 59 and 364 days, your risk doesn't change 3 days later, right? But, it's somewhere you got to draw a line in the sand. It's just the way it is. And that's how the statistics work. And that's how science is done.
And our next question tonight comes from Melissa. And Melissa says, I'm taking Celexa and Abilify for anxiety. She says, is there any concern with drug interactions on HRT?
So with those two particular medications, there really isn't a concern. This is where I get to put my plug in that it's really, really important that you give us a very comprehensive list of everything that you're taking when you fill out the onboarding, because the only way we can know if you're having drug interactions is if we see everything that you're taking. And that includes vitamins, supplements, because there's a lot of over-the-counter menopause relief supplements that are out there. Some of them have some ingredients that we may not want to combine with your HRT. Some of them are fine, but the only way we know is to really know and have that transparency of what you're taking. So, but with those two particular medications, it's fine.
And our next question comes from Sherry. And Sherry says, I have been on HRT for almost a year. She says, I recently started testosterone and my libido has come back a little bit after being pretty much nothing. She says, I have gained about 10 pounds within the last 4 to 6 weeks. She says, I've not changed anything and I'm baffled. She says, I work out all the time. Do you have any thoughts on this?
So the weight gain has just happened after starting testosterone. So it could be related to the fluctuations in your hormones when you're adding a new treatment option. So, when you change your hormone levels or change the medication that you're taking, it can cause some bloating. It can cause some water retention in some patients. But I think it's important too that you really, a lot of us really, if we look back, we think about what we've eaten and we might think we've eaten really good, but unless you actually keep track or keep a food log, we don't always have a mental inventory of all the bad stuff we sneak in. So I also encourage people to do food logging. There's a lot of apps available that are free that you can put your food and your meals into, and it'll actually tell you not only calories, but it'll tell you your macronutrients too. So a lot of women gain weight despite dieting because they're not getting enough protein in. That's a huge factor. And also if you're working out but not getting enough protein, your body will try to retain weight because it thinks you're like in starvation mode. So it's important to make sure you're getting a lot of protein in too. So I would think about that as well.
But if it's really just in the first 4 to 6 weeks after starting a new treatment, it's often water weight. Mm-hmm. It's typically temporary. That's what I would think. You change something 4 to 6 weeks, that's usually water weight.
And our next question comes from Mary. And Mary says, should we expect to sleep soundly again once we find the right dose of HRT? She says, like before perimenopause, or is that too hopeful?
I think it all depends on you and what other factors could be affecting your sleep. I'll tell you, my personal experience has been that I sleep so much more soundly now on HRT than I did before. And I don't remember sleeping this good in a long time, especially as an OBGYN. in general, in this career, we have very disordered sleep. And it was one of those things that, when you have adrenaline and you're having to stay awake all night to wait for a baby, and then when you finally do get to sleep, it's hard to wind down. But perimenopause threw a curveball in that, and I think it does for a lot of patients. So typically when we get the right dose, the sleep quality really improves, and many, many women notice real improvement in that.
Absolutely. Well, it looks like that was our last question for tonight. Oh, actually, we have one more, and then we'll wrap up for tonight. And we have one more question, which is, what about the Winona creams, the difference between the cream versus the patch? And then that will be our last question for the night.
Sure. I mean, they're both transdermal methods, and it's really just a matter of preference. So the cream is something you'd apply once a day and rub in. And it's just a matter of if you think that that's something you can incorporate into your lifestyle better or not. Some women like the patch just because they place the patch. They're not having to remember it every day, but you do have to remember to change it twice a week. So it's every 3 to 4 days that you're changing the patch. Now, however, if you're thinking about the patch, but say you've gone to get your blood work done and you break out from the medical tape they put on your arm after they draw your blood, or you get a residue or a reaction on your skin from Band-Aids, then a patch is not a great option for you because it's going to do the same thing. Because patches have a medical adhesive on them to keep the patch adhered. As long as it's in contact with your skin, it's delivering the medication through the skin. So that's a big factor, I think, for a lot of women. Or if you're someone who likes to go hot tubbing or use saunas regularly, it might be hard for a patch to stay on. So that's something. But yes, they are just as, efficient and efficacious. They, women get the same results regardless of the mode of delivery. It's more about picking what you think you can fit into your lifestyle the best. So
the other thing, if you still have a uterus, the patch is going to require you to take progesterone, usually a pill. So even though you're doing the patch and you're only changing it twice a week, you're still having to take that pill every day. Whereas the cream is going to have estrogen and progesterone in the same cream. So it's just one thing once a day.
Mm-hmm.
And then also there's a cost difference. Because we compound the cream in our own pharmacy, that keeps costs down. And so the creams are much more cost effective, less expensive for you than the patches that we have to buy on the wholesale market. So, but patches are wonderful, as are creams. And it really, it's mostly preference. As far as what's going to make you feel better, get your symptoms under control safely, they're both pretty equal that way, in my opinion.
Absolutely. Well, thank you so much, Dr. Green and Dr. Kat, for giving your time tonight to kind of go over these questions and answer them. I know that we all really appreciate your time, and I know that these women really appreciate them as well. I always personally love getting to hear your answers and kind of going into everything. I think it's really fun. Also, I just want to remind everyone who is listening that also, if you're a Winona patient, your Winona doctor is always available in your patient portal. That is a great place to reach out to them all the time. They are there 24/7. They want to answer your questions. Any of the questions that you asked here tonight, those are great questions to ask them. They love asking those questions. So please feel free to reach out to them. They would love to hear that as well. Dr. Green, I was going to say, Mary says, wishing you well with your knee as well. I saw a couple thank yous in there as well. And if you are listening also and you enjoy these conversations and you haven't heard, we also have a Winona podcast called The Menopause Hour. And so these are great to listen on your way to work, in the gym, on your way home from work, at the grocery store, kind of whenever you like to listen to your podcast. You can kind of get your questions answered there. They're a really, really fun way to kind of dive into your menopause journey and kind of what that journey looks like a little bit more. So those are some great resources for you to check out. Your doctor, of course, you're no doctor, the podcast. And then also we have live Q&As and doctor dialogues like this pretty regularly throughout every month. So we hope that if you love this one, you'll join us for your next one. Tell your friends about this as well. We hope that we'll see you at our next one. And again,
also, if they want to do more reading or learn more, or maybe they just want to dive deeper, we have a lot of really great free information on our website. We have a medical journal page of the Winona site that really has a wealth of information that you can read through to learn more about perimenopause, menopause. Dr. Green and I have both reviewed articles and written some of the articles as well. So there's a lot of wealth of information on there too that they could check out.
Absolutely. I love going through those medical journals as well. We also wrote one recently on the benefits of friendship, which I think is really, really exciting as well, kind of seeing how community can kind of impact your health journey as well. So check that out as well. And again, thank you, Dr. Green. Thank you, Dr. Kat, for your time. I know you both have very busy schedules, so it's always a pleasure getting to kind of hear your answers as well. And thank you everyone for tuning in. And I hope everyone has a great rest of their evening, their night, their morning, depending on where in the world you are right now. So thanks everyone.
Thank you. Good night.
Thank you for joining the Menopause Hour, brought to you by Winona. Menopause care made easy. To learn more, find Winona at bywinona.com and on Instagram at bywinona. Want to have your questions answered next? Register for our upcoming live Q&A, linked in the show notes.